So we're going to talk this evening about pneumopedics and craniofacial epigenetics. So conflict of interest disclosure, I'm CEO and chairman of Biomodeling Solutions. Biomodeling is registered as a medical device facility with the FDA. All the DNA appliances are FDA registered, and the mRNA appliance is FDA cleared for mild to moderate sleep apnea. So all the devices that you will see in today's presentation, they've all been through the approval process. In fact, there are specific billing codes which apply to that DNA appliance system. And here you see some of the patents that go with that technology. So yeah, let's talk about this presentation. You know, Dr. Gimeno, what he said is that there's an interaction between craniofacial morphology and upper airway adequacy. And that's a very profound statement. And what it's really saying is that the shape and size of the face, including the jaws and teeth, has a major impact on the upper airway. And as you know, that is critical for life, for breathing, and for sleep. So what we're going to be doing in this presentation is looking at some of the ideas in terms of what do you mean by craniofacial epigenetics. And that includes things like epigenetic orthopedics as well as epigenetic orthodontics. So these are new words which are describing phenomenon that we'll be seeing clinically, and research is showing more and more support for these ideas. And then tonight I'm going to also talk about the idea of pneumopedics. So orthodontics, as we know, is moving teeth, and orthopedics, as you know, is remodeling bone. And now we have the idea of pneumopedics, which is remodeling the upper airway. Now the advantage of pneumopedics is that it's non-surgical and drug-free. And so that's the idea in terms of working with the body on a biomimetic basis. And so here we're talking about these biomimetic oral appliances. So there are fixed appliances, there are removable appliances, and there are functional appliances historically. And that classification doesn't really tell us how the appliances do their work. In addition, there's several, hundreds of oral appliances out there for mandibular advancement devices for sleep apnea. But what we have here is the idea of a biomimetic oral appliance, which is going to target the site and the severity of the obstruction in terms of correcting sleep apnea. So the overall idea is to apply these new concepts as a potential cure for sleep apnea in a multidisciplinary dental setting. And that, again, is a critical phase because sleep apnea is a medical condition. We're going to be using medical billing codes for the reimbursement side. And so we need to work with the medical professionals specifically for the diagnostic components. And so we know that there are large chunks of patients out there who have been diagnosed with sleep apnea who are unable to comply with the protocol such as a CPAP mask. And we also know that there are many, many patients who remain undiagnosed. And so the idea is to have the medical model in the dental office. And so you'll be working with a medical director who will help you to actually diagnose and review the patient. But you, as a dental practitioner, are actually doing the therapy using these biomimetic oral devices. Does anyone have a bulldog? And does anyone know how many mammals snore? Well, one of them is a bulldog, and the other one, of course, are humans. And so if you have a patient that has been diagnosed with snoring, mild or moderate sleep apnea, currently people are saying that let's use a mandibular advancement device to address that issue. So here's a bulldog, and here he is from the profile. And now we have to ask the question is, do I need mandibular advancement? There are a large number of patients who present to the dental office with a class 3 phenotype, with a class 3 appearance, which means the jaw is already protruded. Now, if those patients also have sleep apnea, the question is, where am I going to put that mandible? It's already protruded. So we need a protocol that can address class 1, class 2, and even class 3 cases. And if we say, well, class 3 isn't that common, let's go to a place like Asia, where approximately 45 to 50% of orthodontic patients present with a class 3 malocclusion seeking treatment. So let's ask another question. The class 3 is, of course, a phenotype, And so now the genes have produced a class 3 phenotype. Can we change this phenotype non-surgically? In other words, can I change this phenotype epigenetically? So we know that the genes are producing phenotypes, but the idea now is that we can have an epigenetic response to actually change the phenotype. In other words, we can take this facial shape and remodel it and make it look different so it functions and actually looks better. So one way of causing sleep apnea is to have deficient craniofacial morphology, but another way of causing patients is for patients to be obese. So a patient who's overweight. So here's a fat mouse from New Zealand, and when this mouse is sleeping, it stands up, and the reason it does that is because it wants to maintain its airway. If it lies down flat, it will squish its airway and it won't wake up. So that's what patients do, is they are going to go into a different posture to try to keep the airway open. That's during nighttime, but also during the daytime. So we have to think about how is sleep apnea caused in various types of patients. Now in the obese patients, they can be depositing fat all over their body, including inside the tongue and including the parapharyngeal spaces in the throat. So if you've got a very large tongue, it makes sense to have large jaws so you can accommodate the tongue and prevent it from causing airway obstruction when that patient sleeps. So let's look at a summary of how the airway can be compromised. Let's take the first row here. These are normal patients. They've got a normal amount of soft tissue. The bony size of the jaws is quite normal, and the airway size is normal. Therefore, they don't have any sleep apnea. The second row shows patients who are obese and they have an excess amount of soft tissue. The jaw size is normal, but the soft tissue pressure is causing airway collapse, and those patients are at high risk of developing sleep apnea. Now the third group is the bottom row here, and these patients are non-obese because they have the normal amount of soft tissue. However, their jaws are small. The bone enclosure, the upper and lower jaws, are smaller than usual, and so we have an increased tissue pressure again, and now these patients are at risk of developing sleep apnea. So it would make some sense for us to say, let's target the tissues that are actually causing the underlying etiology of the sleep apnea. And if you look at the craniofacial region, we've got soft tissues, we've got hard tissues, we've got functional spaces, which of course is the airway, but then we have these special tissues called teeth. So what about teeth? Do they have any impact on the airway, and do they have any impact on sleep apnea? And the short answer is probably yes. And that's a short answer to a very complex question. But here's the thing, is that the teeth are attached to the bone. And so we know that the airway is going to be interacting with the bony morphology. And so can we use the teeth to communicate with the underlying bony foundation? And can that bony foundation then target the airway for correction? Those are the kind of concepts that we're going to be looking at as the seminar goes on. So the basis for doing this is an epigenetic approach. Now we know about genes and the genome. So, you know, what Darwin said is that the genotype is going to define the phenotype, okay? But now we have this idea of epigenetics, and we're going to actually change the phenotype without changing the DNA sequence. So we're not changing the genes, but we're changing the way that those genes are going to be expressed. And those changes are mediated by the attachment of chemical groups to the DNA and the proteins, histones, and chromatin, which surround the DNA. And so that region is called the epigenome. So just think of a Snicker bar or a candy bar. There's a wrapper that goes around it. And so the epigenome is the wrapper which is around the genes, and this wrapper is reactive to environmental signals. And so what we can do is we can get epigenetic modification. These are biochemical reactions that the epigenome undergoes, and that allows the underlying genes to be expressed slightly differently. And so it's a different combination of the same genes, which is actually producing a different outcome, a variation or a change in the phenotype. And what we see here is a list of those kind of biochemical reactions: ribosylation, acetylation, methylation, phosphorylation, simulation, and ubiquination. Now, these look like pretty complex reactions, which they are, but let's take methylation for example here. We often recommend to women of childbearing age that they should be on a folate supplement, taking folic acid. And we know that folate prevents neural tube defects, such as spina bifida, cleft from palate, that sort of stuff, and so we have healthier babies. And so what is the folate actually doing? Well, the folate is a methyl donor. And so there's an example of an epigenetic kind of protocol whereby you've added folate to the diet, and that's produced a healthy baby through an epigenetic process. Now, the human genome, it's a bit like the human epigenome, it's a bit like the human genome. So here's a news article from the New York Times about a year ago. 200 scientists working on this project to understand the complicated system of switches that regulates genes. So each cell has the same number of genes, but those genes have been expressed differently. Genes can be upregulated, they can be downregulated, there's modulation of those genes. And what these scientists are hoping to do is to discover new ways to treat these diseases or even cure diseases. And so this includes diseases such as sleep apnea. There may be a potential cure which is very close to us and almost in our hands. So we talked a little about epigenetics. Now what about biomimetics? What do you mean by that? Well, anyone who goes fishing will know that we can use this little decoy kind of fish here to affect the behavior of larger fish. So what we're doing here is mimicking nature. And so what we see here is an axe. Okay, it's been redesigned to the kind of shape and size of a woodpecker. Woodpeckers are very efficient at removing wood. And so what we're doing is taking a natural model and trying to replicate that to get a better outcome. So what is biomimetics? It's a science. It studies natural models and uses these designs and processes to solve human problems. So we're looking for a natural model of the human. Now what do we know about the modern human? Well, pretty much symmetrical on the outside of the body. Go from the head right down to the toes. The human body is pretty symmetrical, okay? If you go inside the human body, you know, the thorax and the abdomen, there you will find asymmetry. The asymmetry is not an accident. It's actually directional asymmetry. It's part of the whole idea of fluctuating asymmetry. And so what the human body has a natural model to be symmetrical on the outside. Let's think about human enamel. As you recall from enamel is derived from surface ectoderm. And so technically enamel or teeth are on the outside of the body and they're supposed to be symmetric. And then think about the human body. You know, we've got 2 eyes, we've got 10 fingers and 32 teeth. That is the replica, that is the model that we're trying to replicate, and we know that's taken millennia to evolve to a high degree of efficiency, a high degree of survivability. And how we're going to replicate that model? By using specific processes, and those processes are developmental processes. So development is encoded by genes. And those are the genes that you inherited, that you were born with, and that you keep for life. And so what we're going to do is target those genes and saying, can you do some redevelopment, which you are encoded to do, if I give you an appropriate environmental signal? And that really is the basis of biomimetics and epigenetics. Now, more specifically, let's talk about craniofacial epigenetics. What do you mean by craniofacial epigenetics? What are you going to be doing in that craniofacial region? So here's the working definition. Craniofacial epigenetics, I'm going to use a person's natural genes. I'm going to correct and straighten the jaws, the teeth, the soft tissues, and functional spaces. I'm going to do that painlessly using biomimetic appliances. So the emphasis again is on natural genes. This is not transgenics. This is not GMO. This is the genes that you inherited and the genes that you will keep for the rest of your life. we're going to use those genes to remodel the craniofacial structures, the jaws, the teeth, the soft tissues, and the functional spaces, which is predominantly the upper airway. The great thing is that because we're using a biomimetic approach, the protocol will be painless, it will be pain-free. And the reason we can say that is that when a child is growing, they typically don't complain of pain. Pain is due to inflammation, it's a pathologic condition. Growth and development is a physiologic condition, and as long as we don't exceed the biological boundaries, it will be a pain-free process, pretty much free of inflammation. And we know that inflammation is not good for the body, it causes premature aging, and so we want to decrease the inflammatory process and work within that physiological limit. So here's our definitions. At the bottom here, I've got epigenetic orthodontics. So yes, we can straighten the teeth to a greater or lesser extent. So it's almost like a cosmetic treatment, but the thing is there will be health benefits. And this is the kind of key in terms of not only looking good, but actually feeling good. Now we can actually start to improve the tooth alignment because we're going to be doing epigenetic orthopedics. And that involves both bone formation and bone remodeling. And so I'll show you studies that we've done to show that we can actually increase the bone volume of the midface in adults with no surgery and no drugs. And now once that bone is being formed, it will be remodeled so you have a larger version, a better version of the same thing. So we can move teeth, we can remodel bone, and what that leads to is the pneumopedics, which means that we can non-surgically modulate and remodel the upper airway. Now let's go a little bit further down, if we will, and let's ask another question. What makes craniofacial epigenetics different from traditional dental alveolar orthodontics? So we know that orthodontics is focused on tooth alignment and getting very nice smile aesthetics. So what's the difference between these two protocols? And quite simply, craniofacial epigenetics is aimed at the overall health of the craniofacial region. And it does that by providing treatment protocols that address the underlying etiology of the signs and symptoms of sleep apnea, TMD, malocclusions, etc. So craniofacial epigenetics is a broader umbrella, and it will include the orthodontic protocols downstream from that. And so what we're looking at is the overall health of the craniofacial region. So what that means is things like brain health. And brain health could be, short-term and long-term. So let's say you have a child who has, not doing well in school, has behavioral issues, that's looking at brain health, and what we know is kids who sleep well, their grades go up, okay? Now that's kind of, let's take an older person, things like dementia, Alzheimer's, Parkinson's, those are things that happen later on in life. And so if we are able to have a healthier brain, which is well oxygenated, the chances of having, those kind of conditions is reduced. So think about brain health, think about upper airway health. So the craniofacial region is so important because it houses the, the most kind of, the initial part of the upper airway, which is so important to get oxygen into the body and get the blood saturated. So overall of the craniofacial region, think about brain health, and a very acute example would be athletes. Some of these athletes are prone to concussions. And so if we can enhance the craniofacial architecture, we can actually reduce the rates of concussions and improve the performance of some of these athletes. Craniofacial health includes temporomandibular joint health. And so we're saying, why are the teeth not straight? Why does this patient have TMJ issues? Why does this patient have sleep apnea? Or why is this patient snoring? We want to look at the underlying etiology and try to address that by doing craniofacial enhancement if we can. So another question I'm asked is, what makes the Pneumopedics protocol different from mandibular advancement devices? So we know that mandibular advancement is a well-known protocol for addressing sleep apnea in large numbers of patients. But here's an example of a case that was sent to us quite recently. And this patient has been wearing a mandibular advancement device for about 5 years. Now, initially, the patient got some kind of, good response. But now, 5 years later, he's got this very severe anterior open crossbite. He's got this posterior crossbite on both sides. And the worst thing is that, there's no more mandibular advancement available in this patient. And if you take the device away, he has now severe sleep apnea. So when we look at patients, diagnosis is incredibly important, because some of these patients may or may not be appropriate for mandibular advancement devices in isolation. Now, you can use whatever device you like, but we have to think about what would be a slightly better way of preventing those kind of conditions from happening. Let's take a similar patient who was following that biomimetic protocol for the last 5 years, and you can see how his occlusion is at that time. The teeth are pretty much in occlusion, and we don't see any huge dysfunction there. So this is the kind of subtle but significant differences between current protocols and the pneumopedic protocol that we are advocating. How did these concepts arise? What we see here on the screen is a teenager, and he'd been treated for cleft lip and palate by having midfacial surgery, and you can see that the midface here is deficient. And so his midface has been brought forward surgically using distraction osteogenesis. Here's the MRI of the same patient. You can see the deficiency of midfacial bone here. And here he is after the distraction osteogenesis surgery. The MRI shows increased kind of bone changes in the anterior part of his face, which explains why he had a nicer facial profile. The question is, the surgery was done back here, and so how did those changes occur on the anterior part of the face? And the answer probably is through the remodeling process. So surgically, the midface was brought forward in space. The body detected those changes and remodeled that bone and gave it a much nicer facial profile. So we did that study on several patients. And then what I did is looked at the mid-sagittal slice from the MRIs. This is going back almost like 10 years. And looking at how those facial morphologies changed. I'm using finite element analysis. The red means about a 30% increase in size. And we can see the facial profile has improved as expected. We see the midfacial volume has also increased as expected. But then there's another red area right about here. And what that represents is the upper airway. Now remember that these teenagers, the only intervention they had was surgical correction of the midface using distraction osteogenesis. They didn't have any mandibular surgery done. The only thing that was done was to work on the midfacial components. So now we have to ask them the question, can we achieve these types of results non-surgically? So if we can rephrase the question, can we achieve similar results epigenetically? Now we've known for a while that it's possible to do midfacial development in children and possibly in adults. It's an old technique which is previously called palatal extension. So can we use that as a starting point to say, how can we get midfacial redevelopment? So before we do that, clinically, let's look at the idea behind it. So here's the spatial matrix hypothesis, published at the University of Michigan in 2004. And what it's saying is that during growth, the spatial function alignment of the skeletal elements is maintained through remodeling of bony surfaces, including the periodontium, to permit function. So what it's saying is that when a child is growing, the maxilla and mandible, they're kept in coordination through remodeling of the bone. And whilst the bone is growing and being remodeled, the teeth are going to erupt to permit function. And so now you've got the periodontium there. So that's all well and good, except that what happens in real life is that there are environmentally induced changes. So these are normal kids, so there's no genetic component here. They're just growing up normally, but there are environmentally induced changes. And what I mean by that is, let's say a child starts to suck their thumb, or has a pacifier, or is bottle fed, And so what that does, it changes the early morphologic relationship. So instead of the teeth erupting into a class 1 occlusion, this child now has, an increased overbite or an increased overjet, and now they're a class 2. So genetically, they're supposed to be a class 1, but what you've done is change the phenotype epigenetically and made it into a class 2. So what we have here is a variation in the phenotypic variation without changing the underlying genes. So what's going to happen next is the body will respond to that because this new phenotype, this new solution, represents a departure from the genetically encoded body plan. The body plan was expecting the teeth to be in a class 1 occlusion in all cases all the time. And we know that through a thing called temporospatial patterning, each cell in the body knows where it is in space, and it has a specific function in that region. So the body's picking up this departure from the body plan. The body's supposed to be symmetric. It's supposed to have 32 teeth, and those changes are going to be detected. So what the body does, it undergoes a thing called developmental compensation. And the compensation permits compromised function. So I can eat, but my teeth are crooked. I can chew, but I get jaw pain. I can breathe, but I'm snoring at night. And so this is compromised function. So the body works, but it's not optimal. And this is the developmental compensation that occurs. Now, so what the body has done is undergone this compensation. Now let's think about it this way. You're driving from, from New York to Chicago, and the GPS system in your car says turn left, and then you turn right by mistake. What happens then is recalculation. It says do a U-turn and come all the way back. So the developmental compensation is the recalculation the body does because it's got the body plan encoded in the genetic blueprint. So it's comparing what you have clinically in real life with what the body expected genetically. And so what the body will do is try to compensate for that, saying, do a U-turn, come back to where you are supposed to be if you possibly can. And that is what we're going to do clinically. We're going to do decompensation. Decompensation is done through appropriate spatial signaling. Remember, the body components know where they are in space, and so if you change their spatial alignment, the body will pick that up and try to reestablish the genomic pattern formation for the best form, the best function. So clinically, if you got a class 2 case with an increased overjet, I'm going to bring the mandible forwards. If I've got a narrow palate, I'm going to widen the palate. If I've got a posterior crossbite, I'm going to have to correct the spatial relations, so on and so forth. If I've got a deep bite, I'm going to increase the vertical. So step 1 for the correction is simply the decompensation, bringing the components close to where they should be. So let's say that the mandible is off-center and there's a midline discrepancy. I'm going to physically move the mandible closer to the midline of the body, and then what's going to happen is the body's going to remodel the tissues into that new spatial matrix if you have the appropriate signaling. So you think it's a good idea? Well, here's a paper that just came out just last year, and what it says is mind the gap, genetic manipulation of basic cranial growth, chondroses, modulates covarial and facial shape in mice through epigenetic interactions. So this is a very interesting paper. So what is the gap that they're referring to? Mind the gap. What do they mean by that? The gap, in my mind, is the genomic thesis saying that the genes are going to determine the phenotype, and the epigenetic antithesis, which is saying you can change the phenotype without changing the genes. Now, in between those two extremes, we have the genomic thesis, we have the epigenetic antithesis, and what we have in between those is the resolving synthesis. You take those two bits and make them work for us clinically. So what happened in this case, in this paper, is that they changed the cranial base in these mice, and they did it by doing a genetic intervention. They genetically induced a mutation, so the cranial base of these mice was different. Now remember, the face of the mice was not changed in any way genetically, but they got a facial shape change in the mice through epigenetic interactions. And so what we're saying here is that we can use epigenetics to modulate, change, remodel the facial shape in humans. Because what we know is that there's homology in the human genome, which means that mice, monkeys, and man, those species all have homology. In other words, if a gene produces a tooth in a mouse, that gene probably produces a tooth in a monkey and probably produces a tooth in a man. Okay, and so there's good scientific foundation to show that there's, a support for the idea of epigenetics and clinical correction. So what about pneumopedics? What do you mean by pneumopedics? Well, this is the actual clinical protocol of non-surgical upper airway remodeling, and it may result from treatment with a biomedical oral appliance. So what do you mean by that, and how does it work? Well, the biomedical oral appliances, we're going to apply the principles of epigenetics, and we use the person's naturally occurring genes to correct craniofacial deficiencies. So remember, if you've got small jaws, you've got crowded teeth, you've got a small airway, those tissues, and we're going to remodel them over a period of time. We're going to change the structure of the upper airway non-surgically. The great thing is the protocol is pain-free, it's minimally invasive, it's drug-free, there's no medications or injections. It sounds too good to be true, but this is genetic potential. The human genome is robust. It's taken thousands of years, millennia, to get it to this point of refinement. And so what it's built for is survivability. You want to have longevity and you want to have health. Let's harness the power of your own genes. So during that pneumopedic protocol, what actually happens is the craniofacial region undergoes structural changes, so the functional changes of the upper airway increase volumetrically, and I'll show you that in a few moments. So what happens is you have improved basic functions such as breathing during sleep. Now if you want to be healthy, there's 2 or 3 things that you want to get really under control. Number 1 is what you eat. Number 2 is your lifestyle in terms of activity. And number 3 is the quality and the quantity of your sleep. So let's get those 3 things under control. And here we're talking specifically about breathing and sleeping. And because of this pneumopedic protocol, we can use a system of biomedical oral appliances to treat, reduce, and eventually eliminate sleep apnea, because it's going to redevelop that upper airway. Think about someone who's obese, overweight. They get on a good nutritional diet. They start working out in the gym and improve their exercise routine, and they lose weight. They increase their muscle tone. They increase the density of their bones. And so what we're doing here is saying, can we use the genes to improve the health of the upper airway in a kind of similar manner to kind of working out in the gym? Can we do something similar to redevelop the airway and remodel it over a period of time? And these are our adult patients that I'm talking about. So if we're going to be working in adult patients, let's look at the dental arch morphology in these adult patients with sleep apnea. So here's a sleep study that we did on 108 patients. It was done in a university ENT sleep department. And what we looked at is the size of the upper jaw and the size of the lower jaw in patients with sleep apnea and patients who didn't have sleep apnea. And as you might have guessed, the patients with sleep apnea, they had a smaller upper jaw. And what this color coding shows you, the circular scale shows you, is the direction in which the change occurred. It's like a concentric collapse of the upper jaw. And at the same time, the lower jaw, the mandible, became narrower. So these patients may be retrognathic, but in addition, they have a deficiency in the midface. So it's almost as if they've got bimaxillary retrognathia. The mandible is protruded, retrognathic, but that's kind of almost like an optical illusion. Our eyes will see the chin is receded, but what we won't see the fact that the midface is deficient, and so that mandible doesn't have sufficient functional space to move into. And so what we want to actually do is target the midface, and then allow the mandible to come into that new functional space. So here's an example of a patient who presented to the office with sleep apnea. And you can see that she had, orthodontic treatment as a youngster, and her teeth were very well aligned and everything was fine. But over a period of time, you know, the teeth have become crowded and there's some kind of relapse here. But again, that's not her main concern. The concern here is that, you know, the diagnosis of sleep apnea. So what we're going to do with this patient is saying, well, let's recapture the functional space. And now what we see is the space for the first premolars has been pretty much recaptured, not quite there. A bit more refinement needs to be done, because what the body is looking for here is functional space. Now, the spaces that you see between the two teeth here, what is filling that space? Well, underlying the mucosa here is bone. And so if teeth start to become spaced, it's showing you that the underlying bone volume is probably increasing. I say probably because if you start to tip the teeth, then you'll get spaces, and that's not part of the protocol here. And so what we want to do is allow those teeth to move with the bone, increase the bone volume, increase the amount of functional space, which means that the tongue can actually sit on the palate for the first time and not fall back into the throat when this patient is asleep. So that is kind of an idea in terms of where we're going with this. So let's take an adult case. She's 38 years old, diagnosed with moderate sleep apnea. And this is the first case that we did, published case that we did back in 2011 with Dr. Sue Wendling, who's from Oregon, Lake Oswego. So you can see a similar idea here where the premolars have been extracted for orthodontic reasons. And what we've done is recaptured some of that bone volume in the anterior section here. The teeth are spaced because it localizes space to the premolar region, in this case, as we did in the previous case. In this case, the patient did not want the implants done, some buildups to close those spaces at the end of treatment. But you can see in a period of about a year or so, the intermolar width, and that's the bone width, the mesopalatal groove of the first molar at the cervical margin, it's actually the bone width here, increased from about 34 to about 39 millimeters. And there's the bone volume there. Now look at his airway volume during that time after treatment was finished. Here's the cone beam pre-treatment, and here's the airway post-treatment. And the upper airway volume actually increased by about 70%, from about 12.8 cc's to about 22 cc's. So here's the first patient that we're able to measure and show in 3D that the airway volume actually increased. And next you can see the reconstruction of the airway here. You can see the site of obstruction airway after about 18 months. Now remember, there is nothing in patient mouth when either the sleep study is done or when the 3D cone beam analysis is done. So now the question is, if his airway volume increased in size to his sleep apnea. Well, before treatment, his apnea-hypopnea index was 24 events per hour, which is moderate sleep apnea. And after about a year or so, it's come down to about 3, it's less than 5. And remember, no device in this patient's mouth when the sleep study is done. So this was the first time we were able to show that it may be possible to potentially cure sleep apnea in these adult patients. And if you look at this case, after treatment, you know, the tooth alignment looks good. He's been filled here with some very nice veneers, cosmetic finish at the end. And we can see the head posture has also improved after about 12 months or so. And so this is really the craniofacial enhancement that I mentioned earlier on. Now, the study that I've just shown you was cited in 2013. And these are authors in Sleep and Breathing. What they are saying is the published studies show evidence of cone beam measured anatomic airway changes with surgery and dental appliance treatment for OSA. So the dental appliance they're referring to is the case that I just showed in the previous slide. So we were the first to show that you can actually anatomically change the airway on a cone beam for these patients diagnosed with sleep apnea. Here's another case. She's been going to the dental office, wearing the device when she's sleeping. And what I want to show you here is kind of the cosmetic enhancement of that facial appearance in this young lady. And her upper arch, the teeth are a little bit better aligned. The lower arch, you see the teeth are slightly better aligned also. But look at the position of her tongue. See the asymmetry of the tongue here before treatment? It's become more symmetric after treatment, and there's more space for that tongue to be accommodated in the palate. And we know that the bone volume increased in this patient because the gray represents the cone beam pre-treatment, the blue is the post-treatment, and they've been superimposed. It's mostly blue on the right side of the patient, which means that the maxilla has got wider and larger on the right side predominantly. The mandible has moved into the right side. So why do you get this asymmetric change? Let's look at the patient's face. And what we see is that the nose is obstructed on the right side of the patient's face. So the body is remodeling the maxilla, making it more symmetric and getting more functional space inside the patient's nose for improved breathing. Look at her airway. The upper airway increased in volume from 17 to about 28 cc's. So here was a second example where you can actually volumetrically measure the airway changes into adult patients pre and post treatment and show how it improved. So this is what we mean by the pneumopedic effect. And remember that the studies are done with no device in the patient's mouth. And here's a different example. This is a patient who is 60 years old, that's 60. And here's a pre-treatment airway before the treatment was done. And here it is after treatment. That took about 18 to 24 months. And you can see the airway has virtually doubled in size. And so this is showing you the pneumopedic effect. What happens with the teeth and the jaws as you start to develop the midface? If you follow the protocol, there will be no spacing between the teeth or little spacing between the teeth, and the bone width seems to get wider. So is there an increased bone width in these adult patients? Notice there's no diastema or spacing between the teeth. Does the bone actually get wider? We actually measured it, and in average it went from 33 to about 35.5 millimeters. So the bone does get wider. Does the bone volume increase in these adults? In this example here, went from 4 to about 15 cc's. That's about a cc of bone. And then if you look at the actual study, we were awarded the whole prize for that in 2013. The bone volume increased on average from about 17 to about 19 cc's. And so there's about 2 cc's of bone in these adult patients. Our colleagues from Europe did the same study, but they did it surgically. They did it surgically assisted rapid maxillary expansion. So now we're going to compare the pneumopedic protocol and this surgically assisted protocol. And what they found is positive distances on the right and left posterior segments of the maxilla, indicating lateral expansion. So did the bone get wider? Yes, it did. But the anterior region showed negative distances, posterior displacement of the anterior ulnar segment. So when you do it surgically, the bone does get wider, but it's at the expense of anterior retraction. You can see the bone is green and green. It got wider here, transversely got wider, but the anterior region showed a negative change. There was retraction. So here's a patient who's been told that he's a surgical candidate, but he doesn't want to have surgery. And so we don't want to bring the mandible any further forwards in this case. He doesn't want to have surgery. So what we're going to do is we're going to midfacial redevelopment on this 24-year-old adult. You see the anterior and posterior crossbites on both sides. Here is pre-treatment, and here is about down through. Again, it was done, and no drug was used, and we were able to increase that midfacial bone volume for this adult patient. Here's a different patient. We're going to again look at the intermolar width. So the cone beam has been superimposed at pre and post treatment. Pre-treatment, the intermolar width was 31 millimeters, and post treatment increased about 35.5. Airway, you can see the airway. From the lateral point of view, it went from 2 and 5 to 4.5 and about 8 behind the tongue. So that's what we mean by the pneumopedic effect. As you start to redevelop the midface, the airway simultaneously. So looking at this case, from 31 to 35.5, the airway improved, and then you see the models where the arch has been improved. And this is her appearance becoming here. It's about 24 months later, and again, no. Should be biometric. itself to get that craniofacial coverage. Different patient dentists gain a pneumopedic effect in the upper airway to start 9.5, getting 13.5 behind the palate, 12.5 behind the tongue. And you can see the mandible has moved forward. This is the new place for that can move forward into enhance the upper airway. It remodels into that phase. That's what I mean by the pneumopedic effect. Different dentists, you can see the upper airway volume to begin with, and here it is at the end. It starts at 11.8, the 41 concentrational area. The doubles in size with 27.5, and the cross-sectional area is also very significantly increased. Again, no device in the patient's mouth when the sleep studies are done and when the CD counts are done. The count being in the daytime and the sleep studies done at night, and there's a correlation between the two. So here's a study that we did to see can we change the nasal cavity volume in our adult patients. And we took these count beam scans. The patients were about 38 years old, took about 18 months of treatment. And the cases had mid-facial hyperplasia. And what I mean by that is things like a narrow palate, maybe a posterior crossbite, and maybe an anterior crossbite, those kind of conditions. And so what this slide shows you is the volumetric reconstruction of nasal cavity. So we took the 3D count beam. We're going to work on this very specifically to remove the exit from here. We're going to reconstruct the nose here in 3D. And so here's the reconstruction. There's sinuses on both sides of the nasal cavity. You can start removing the sinuses, left with the nasal cavity. Before treatment and after treatment. And this will test to see did the nasal cavity volume change in these adult patients. So let's look at the nasal appearance of one of these kind of patients. You can see the asymmetry of the nares is kind of slightly narrower, it's kind of slightly broader. And look at the same patient after about 18 months. The nares has kind of opened up and become symmetric. And so that's going to enhance nasal flow into the nose because the upper inlet has improved. Look how kind of, the breathe-right nasal strips, that's how they work. They take the soft tissue, the alar cartilage of the nose, and bend them upwards. And we've done that without a device on the outside of the nose by wearing the device on the inside of the mouth. So what happened to the nasal cavity in this patient on average increased from about 39.8 to 42.3 cc's in the period of about 18 months. And actually we got a small prize for showing that years back. So here's our call from Europe, and they're going to do exactly the same thing, but they're going to do surgically. They're going to do surgically matter expansion to measure the volume changes of the nasal airway. And the story shown on an average, and the higher clients after the surgery has been done, and nasal air volume increased 9.7 average. So let's see what they did. They did in 3 parts. First of all, they did a laphrostomy. Second, they did a midline osteotomy. And third, they did the pterygomaxillary disjunction. So they took the maxilla and basically split it horizontally, vertically down the midline. And then after that was done, they put in a Hyrax appliance or tissue-borne distractor, and the patient wore that 24/7. And these are 2 examples of the post-treatment results. And you can see that, the nasal cavity is one we're going to be looking at. We know that it got increased volume by 9.7%, but what we see are these huge diastemas which need to be closed at the end of treatment. You compare that with a non-surgical protocol where we have, increased nasal cavity volume, but there's no between this, in this example, this is pre-treatment, this is post-treatment. Both of these are post-treatment. You can see a big diastema here and here, but not in this case. So if we compare the 2 protocols, the surgical procedure was in 3 parts for 1 mid and the pterygomaxillary osteotomy. Here there was no surgery. The average treatment time in this study was 2 months. the wear time of the device after the surgery was 24/7, other correct or distractor. In our protocol, that you wear the device 16 hours per day, late afternoon, early evening, all night, but not during the day. Sample size was 1. The first was 9.7, after 5.6. You got a very large data in all cases. So we have a choice. You can actually do the protocol surgically, or you can do it non-surgically, and that is the decision that you and your patients will have to arrive at. But let's look at a patient who took part in the study. Here she is before treatment. We can see she has very narrow nares, not obvious malocclusion, and see the kind of double chin, a wide neck, and so the diagnosis here includes sleep apnea. And this is the same patient after about 18 months or so, and she looks like a happier and a healthier patient. And so this is showing you some of the genetic potential that's available for these adult patients. Now, if that nasal cavity volume did increase, what would be the effect on adults who've been diagnosed with sleep apnea? So we said the bone volume increases, we said the nasal cavity volume increases. What would happen to the sleep apnea in these patients? So let's do a study to see if the upper airway can be enhanced in patients diagnosed with sleep apnea, so that CPAP, lifelong CPAP, might become avoidable in some of these cases. So here's the study that we did. There being the adults of the age of 21, mild apnea. The heart sleep test was interpreted by a board certified physician or by a single dentist or ribbon, and she's got advanced training in sleep medicine. The apnea hypopnea index of the study sample is calculated multiplying the amount when the sleep studies are done. What did we find? On average, the sleep apnea was 13, decreased to 4, and statistically significant, 68% decrease in the HI. And again, no apply. Some of these patients, this one here, not this one, but some of these patients here, not this one here, are less than 5, which means that the sleep apnea is eliminated. I presented World Association of Sleep Medicine in 2015, and I can say the paper was very received with a lot of excitement from my medical colleagues. And the paper has been published, and again, what the studies show is that there was no device in the patient's mouth when the sleep study was done, and the apnea-hypopnea index came back at less than 5 after those cases. Now, what about patients with severe? So here's a 20-year-old female lady, and she's presented to the dental with signs and symptoms of TMJ issues, and she was screened for sleep apnea, and the healthy came out with an HI of 105, which is, you know, she went for a PSG, it came back an HI of 118. Okay, so this patient has this. She was referred to the ENT surgeons, and they did it for her. To me, the HI came to 70, that's 70, still sleep apnea. So she was advised to be controlled on CPAP. Unfortunately, as a young lady, she did not like the CPAP and didn't tolerate it very well. So she wants a different protocol. So we said we could try a system and see what happens. And she was for about 9 months with CPAP because she has severe sleep apnea. But after about a month or so, when the sleep study was done, the HI came down to 1 without CPAP. Well, patients. So the study was repeated on 6 occasions, 6 different nights. We did the sleep come back and on. Is the appearance of that patient. You can see that the airway is obstructed. Here's the tongue. The tonsils are touching, kind of kissing tonsils. You can see that behind here, and you can see the airway post-treatment. And this is the sleep study that was 3 weeks with no device in the patient's mouth at all. She'd seen the last 3 weeks with no device in the patient's mouth. She goes to the sleep study, And what the pulmonologist we found is that is faulty, and this patient has no feedback without the device in the patient's mouth. So the potential product that can reduce moderate and severe cases. And here's the population for the cases. You can see that after 10 months, the age went from about 46 down to about 16.5, 64% reduction on average, with no device in the patient's mouth when this is actually being done. So this is work in progress, but it shows you that the study has been published, showing you that it may be possible to work with a patient mild, moderate, even severe apnea, relying and get sleeping physiologically, increase the quality and the quantity of the sleep. What we can say that can be obtained in ongoing models, and what it suggests is that there's a genetically coded mechanism that can be regulated by these biomedical appliances to enhance the upper. And so these are the key words, because showing you what we do and how we do it. So what we believe is there's an underlying genetic mechanism, and we're trying to use the body's genetic itself. Just think about get an injury, or you sustain a cut, or you bruise, break a bone. The body's first intention is to undergo a healing process. Now so this is a bone fracture. You put a cast, a move of a crutch, to allow the bone to heal. And when the healing process is done, you start removing the crutch and you remove the cast, and you're back to a physiological state. So think about that of how we rehabilitate the airway. We could put a splint in there. It could be a pneumatic splint in terms of you blowing air down there, so the CPAP, or it could be a pharyngeal stent or a device that goes in the patient. But it's there for a kind of a finite amount of time to allow the healing process to go on. Eventually wean them off the device. And so what we are suggesting is that these findings may help dentists manage patients with sleep apnea, use this pneumopedic and a protocol and the underlying concepts of craniofacial epigenetics. So that pretty much brings the presentation to a close. I want to thank you for your attention.